I am delighted to introduce
slides,
Dr. Osama Naji. Now, Osama has such a lengthy biography. First of all, I'm pleased to say that in South London, apparently, it's also an issue with PowerPoint. Now,
Never heard of it.
dear. But anyway, Osama is now consultant gynecologist at Guy's and St Thomas's, and he leads a lot of their outpatient ultrasound diagnostics.
We did nothing.
And also is doing a lot of minimal access and robotic surgery. Now, Osama, I looked you up on ChatGPT because I thought this would be an interesting part of the introduction, and I sort of said, right, does Osama Naji know anything about caesarean section scars? And this is what I got.
And they said nothing.
Osama Naji knows nothing. No, he said, Osama was the first researcher to systematically study and standardize the ultrasound imaging and measurements of caesarean scars, particularly with vaginal scanning. He was the first person to treat scars as a distinct measurable entity, study them systematically, focus on the reproducibility and measurement reliability, and link imaging to clinical relevance. Which basically shows you that ChatGPT is pretty useless. That's all I can say. So thank you very much. Over to you.
Thank you very much. Good afternoon. Thanks to the audience to spare us their time on a very exciting month of the year to help us to break. And thanks to Dirk and Tom and to Iswak for organizing it. And thanks for the kind invite. I hope you'll find this meeting today helpful and informative. We inherited this subject with Tom for a little bit of a longer time, because I started the journey with them in one of the cupboards in this building almost 20 years ago. And then I have been sent temporarily to an exile to work with Siobhan Quimby, mainly to make a coffee and a little bit of research for 3 years. And then after that, we got exiled back to a less charming building, which I joined the organization now since 2020. And now we're going fully industrial in this building on the right-hand side. As a background, very brief background to onboard you, I'm a consultant gynecologist now. I started the organization currently in my workplace since 2020. And I have been fortunate enough to work with those two titans to master a skill that can be transferred, although I have now moved on from the caesarean scar work, but with the good knowledge about its implication, because simply we managed to master a very valuable and indispensable skill that could save life, and it also could define your career for a very long time in a variety of aspects of women's health, which is simply as a stethoscope to the cardiologist, I call it, as an ultrasound to gynecology practice. I work mainly with the cancer diagnostics work now, but we're maintaining simply because of the ultrasound for in variety of aspects, fertility, early pregnancy, and cancer. And the main research now developing is in how we develop a value-based healthcare within the diagnostic imaging. And of course, and hopefully remain to be no conflict of interest. Please, over the last maybe 10 to 15 minutes, we will talk about a little bit of a background on surgical trends in caesarean birth and what is the global challenges facing this practice. And we will display a little bit of definitions and nomenclature about how the caesarean scar naming and definitions have changed over the last 20 years, and how we can leverage now on a modern, on-the-spot diagnostic imaging for it, and which has now been, as a result, proudly has featured on one of the FIGO classifications for abnormal uterine bleeding. And then we can touch on caesarean scar pregnancy and its management, and hopefully we can conclude with a collaborative, thought-provoking point. The trends, this is a paper almost 3-4 years ago, and it's giving us an alarming trend. Oops, sorry. There you go. So if you look into this point graph, how becoming pandemic this caesarean delivery is, and if you look into the probably overall the world, it is on the ascending. Now, Siobhan earlier said in the UK we are hitting on the 60%, but on most striking areas in the world is in Africa, in Asia, and in the South America. Again, you look into it, there is a global and health economic ramifications from that. This is an operation, unfortunately, attracts emergency care. And the emergency care becomes very hard to standardize the surgical practice. This operation can be done at 5 a.m., can be done in the middle of the day. It can be done by people who has done thousands of them. It can at the same time done by people maybe their first operation. So therefore, conducting research behind the long-term sequelae of this operation becomes very, very difficult to standardize. There are different techniques behind closing the uterus, which is the main culprit for incompletely healed caesarean scar. Imagine it as a very simple cut. Number one, patients and we heal differently. Is the operation complicated or not? Was there a diabetes? Was there hypertension? Is it an infectious process? Is it a complicated process? Was there a decidual sparing technique in the operation? Was there a 2-layer, 1-layer? Is it a continuous? Is it locking? Is a lot of factors. So therefore, unfortunately, in those two, especially, which I'll concluded in my last slide, about those 3 areas, just remember, I would like to ask, hopefully, a question that could qualify for these. Another factor, women probably are consciously or unconsciously, voluntarily, involuntarily delaying childbearing. So therefore, the number of children per the household and the family is getting less and less with time. So therefore, maybe cesarean section is a safer option to them. And unavoidably, these are factors beyond any control for any research. With those 3 regions in the, I don't know how the health economics can help to diagnose and manage caesarean scar sequelae in these, whether the diagnostic images are well developed in these areas and whether these women, they deserve the care that they need. So these are a lot of questions that could heal back. So whenever you come, if you do an ultrasound scan yourself, you come across a lot of these factors, different shapes, different lengths, different positions within the lower uterine segment. And you come across it when there is a pregnancy doing well on board. You ask yourself, while I counsel, I focus, yes, baby probably doing well. And then the next question, does it matter, these ones now? Of course it does. The answer is, you look at these probably so far, what we have established, whether caesarean scar pregnancy, there is an evidence that could cause unscheduled bleed. And we see them a lot in the cancer diagnostics clinic, probably in the early 40s now that people qualify for the referral. When we see nothing wrong, panicking the woman, there's a suspected cancer pathway referral, and we see probably incompletely healed scar, which acts as a reservoir for uncirculating blood. It's simply because of this process rather than a cancer suspicion. There is, as mentioned earlier by Professor Timmerman and the other colleagues earlier, Shabnam, implantation problem, early pregnancy complications, abnormal placentation, and also I remember Siobhan hopefully watched the space. There is evidence probably in the horizon coming, probably a preterm labor as well could be caused by caesarean section. The interest in naming what is this ultrasound finding has been almost now probably over the last 10, 20 years. And there are several studies describing them, ranging from either anechoic area or any indentation or a filling defect or a detectable myometrial thinning. Every research group, they'd come across with a term. So therefore now at the start of the challenging for this area in the research is to defining a common language. We need to talk the same. If we are all doing ultrasound scan, it means when I describe something or when I send you a report, it means you need to know what I'm talking about so that you can interpret it to yourself and to the patient. So it's been ongoing interest for the last 20 years. And then we came to ride the wave at some point when working with Tom and Dirk. And then we ignited, like putting this interest a little bit on steroid. And we designed a little bit of one of the first papers to call for standardized sharing a common language in naming this caesarean. And it has been a very good appetite for joint efforts and joint work among other research groups, which we will mention their work after this. They acknowledged this area of research deserves to have a shared common language, that we need to talk the same description, so in order to standardize future research for it. But as a simple description for it, at the time, based on our research findings, we decided and agreed to call it as a hypoechoic indentation at the anterior wall of the lower segment. Should be ideally measurable in 3 dimensions. And the only one of the factors we looked at the time is whether the caesarean was done. Among all the other factors I mentioned, purely one and important one is whether the caesarean was done emergency or elective. Quite often in emergency cesarean section, because of the thinning, you tend to go unavoidably low. So one of the factors to be looked at ideally should be done in, like I said, in 3-dimensional, the sagittal plane and the transverse plane. And then you could argue whether you call it this is a depth or width or length. It depends how you orientate it and how you interpret it, which has come into a common grounds afterwards. But at the time, that's what we probably agreed to propose to name the dimensions of the scar. So in the first trimester setup, we propose a little bit of an SOP criteria, standard operating procedure, how to call it. It should be ideally in a panoramic view, at least 50 to 75% magnification. You put the sector in a full length in the sector width, and you should be able to see the cervical mucosa and as well as the endocervical fold. And the location of the internal cervical os is also important. And then you take these measurements, and then you can develop the data subsequently. Until came this other paper here, it was a very welcome, huge joint effort from a Dutch group. They agreed now, it's about time to this ultrasound finding. It deserves a proper standardized research. And it came across this very good paper that talked about and called for using a standardized definition for the consultation and the symptoms resulting from the symptomatic uterine caesarean scar that allow better recognition of this condition, and in order to allow safer and more effective patient care, and most importantly, avoid over-treating. And part of the common problems that we face, which I see it increasingly common as well, about for the sequelae of incompletely healed scar, particularly when we see some colleagues from our fertility clinics to ask us for some input, is essentially when they are unable to pass the embryo transfer catheter, it gets stuck. And not necessarily because of the caesarean, when sometimes you get scared. It's probably fibrosis, probably scarring. You might often find these patients might have had cervical conization before. So it's a very, very mixed area. So therefore, it comes in the history, whether when you call it caesarean scar cause infertility or subfertility, it may not be exclusively. Yes, it is a factor, but again, it deserves a little bit careful attention into the history and very careful ultrasound assessment from people who've been doing this ultrasound for a fairly good time, in order to give reliable results to the colleagues putting their trust in your report, so that they can guide management. Again, another part of research, when looked at it in the non-pregnant state, just to give you an evidence, this is a finding that could cause symptoms. And then they looked at into a cohort of in excess of 260 women, and they compared it between gel installation sonography or ultrasound scan, and followed up to 3 months after cesarean delivery. And they did it as the outcome measure of the menstruation score at these time points. And they found, in fact, that post-menstrual spotting, which is unscheduled uterine bleeding, it does happen, and in up to 30% of these women with incompletely healed scar. And particularly when there is a residual myometrial thickness quite thin, less than 50%. Again, is this a factor correctable or not? It's very difficult. How can we predict how it can be managed? What is the proposal for these findings? How can we manage the healing and the surgical repair of these scars. And again, if you remember the Figo class is a palm coin. It is becoming one of the recognized potential causes for abnormal uterine bleeding, although it is coming non other specified, but it does fall under this criteria, and simply because this defect acts as a reservoir for unhealthy, not necessarily unhealthy, but unphysiological menstrual contents that they are not expelled in synchrony with the rest of the myometrial contractility, and often probably gets expelled at a later stage in a form of abnormal bleeding. And therefore, when we see it from the fertility clinics, when there is a free fluid, anechoic fluid in the uterine cavity, which is kind of a very implantation impairing factor that the fertility clinics they don't like it at all. It's probably because of these reasons too. After excluding these factors, if you can probably to the main concept of the series of from this session, which is an abnormal pregnancy, as Dirk elucidated earlier, caesarean scar pregnancy is probably not common yet, but we are getting better at detecting it, simply because of the advancing in the imaging modality, because we share common standards, share common definitions, and that's why the idea from these courses is to spread the knowledge and hopefully spread the word that you can talk the language on how to describe these abnormality. And the definition is the most common agreed known now. It is part of the ectopic pregnancy spectrum, provided the woman has had a previous cesarean section, by the way. So quite often they sometimes to tell whether this is ectopic, but you find the history there is no cesarean. It was described earlier on, almost now 50 years, and it was recently estimated 1 in 500. I have to say this prevalence is getting less and less. Currently, it's much more common than that. And the ultrasound finding, which is the main primary tool for it, it's classified into now endogenous and exogenous. It depends on the protrusion, similar to the interstitial pregnancy Dirk explained. This pregnancy, especially if it is proven to be a dynamic attracting blood supply, they have the tendency to grow, and the growth can sometimes be unpredictable, whether inwards or outwards. Presentation, like any other extrauterine pregnancy, these pregnancies are not destined to be normal. So most of the times we get fortunate to come across some symptoms to raise the index of suspicion, especially vaginal bleeding. It's quite one of the red flags for the pregnancy. An indication might not be doing well. Pain or pain without a bleeding. And if we are lucky, quite often we find it sometimes incidentally for asymptomatic women. And hopefully we should not reach into this collapse. And that's why back in the initial slide, globally, when these people, this is the main high-risk group. We should not be reaching this state in anywhere in the world. It's quite catastrophic if we are reaching, which means we are failing on this point to deliver the safest care. To diagnose it on ultrasound, basically you need probably 2 or 3 criteria, not more than that. Essentially, you need to achieve an empty cavity, that it is evident, that you need to put it in your description, in your ultrasound report, so people, they know that you have looked and you are aware of what to look for. And then a clearly visible empty cervical canal, simply because Dirk mentioned the cervical pregnancy can be one of the overlapping findings. And the presence of the sac with or without the fetal pole, irrespective, with or without fetal cardiac activity as well, in the anterior part of the lower uterine segment, and the absence of absence or a defect in the myometrial tissues. So if you are able to put these the descriptions in the report, then at least whoever is going to read it, if you are primarily focused on ultrasound scan and the people expect some results so that they can plan their management, then they know these are the language that we need to look for, and they can base their management safely based on these findings. And the management, like any other extrauterine pregnancy, again, expectant, not very crystal clear area. This is individualized, often better within the multidisciplinary team. It needs to be within a very strict safety netting. Like Dirk mentioned, if the lady is a sensible adult, accompanied by a sensible adult, living within close proximity to her health facility, and aware of the consequences where to report any problem, then quite often maybe the body can recognize this pregnancy is not doing well and maybe beat us to the job without any intervention. And then we follow exactly the same trends for any extrauterine pregnancy. We, based on individualized, based on fertility wishes, based on previous other risk factors, to whether previous surgical history, whether the hemodynamic status. It's a lot of factors, but there are options available ranging from medical and surgical or even interventional procedures. And to conclude, an ask and a question for all of you, given the global trend of these abnormality and the global trend of increasing cesarean section, can this condition one day hopefully qualify for a screening? That's my question to you, and I'll conclude my slides. Thank you very much.
Thank you very much. Very beautiful lecture. Any questions?
Oh, thank you, Salma. That was fantastic. So what I wanted to tell you is, since you work with me, in the preterm clinic, we started looking for the scar niches in people who had full dilatation sections, and we could see them in nearly everyone. And actually, you can see something in nearly everyone. And I think the problem now is differentiating between, if you look, you can see these things.
Indeed,
it's just
yeah.
is what is a scar and what is a scar niche.
Yeah.
And then, given that if you look hard enough, you can see something in everyone who's had a section. I'm worried that the gynecology community are now over-treating them. And do you see what I mean? So I think your definition needs to keep going.
100%, Siobhan. That's why the idea and the call to share some common understanding and some common definitions. And you've said it in your slides. Do no harm. First, observe. If you are able to observe and avoid intervention, generally intervention is better to be avoided in any circumstance. And therefore, if it is after adequate counseling within the multidisciplinary approach, conservative management can be considered in this exactly to avoid any adverse treatment.
So I think if in a non-pregnant scar, I mean, basically you're better off using gel, and then that clarifies a lot about what's going on with the looking at contrast.
Saline is equally effective, actually.
I'm a gel fan. I'm a gel fan. I mean, it's still a gel. I like a bit of gel. Can't go wrong. No, but there's some sort of contrast to look at it, because you tend to, they become clearer. So I think significant niches are sometimes better. I think, also in the nomenclature, niche versus defect, whatever, because we're not always certain that what you see is actually a defect.
It's a CSD now, please. Hopefully we can agree on cesarean scar disorder.
I mean, we are getting to a point, actually, with cesarean scars where it is quite difficult. I mean, we see people who, I've certainly seen cases where you see a large niche in early pregnancy, and then something happens later on and you're criticised for not terminating the pregnancy in the first trimester. And I've seen a few cases like that, medical legally, where they've sued because they said that pregnancy they should have been told not to carry on, but there's no evidence to intervene at this stage, it's getting quite a problematic area. Could you say something about, when you talked about treatment, right? I mean, it's really gestationally dependent, and also the type of scar pregnancy, isn't it, really? And I think at one point I'm old enough now that it's extraordinary. I remember when I ran the early pregnancy service at George's, we barely saw a scar pregnancy, mainly because we didn't diagnose them. And basically what happened was, people would go to theatre and suddenly find they got blood all over the floor. And it was obviously a scar pregnancy, which we hadn't even considered. And then everyone became incredibly terrified by the idea and thought everyone had to be embolized. And then a more rational approach has been adopted, where at a certain gestation, earlier gestations, actually it's not much more different very different to a normal surgical management of miscarriage. And it's only at the later gestations it's actually extremely problematic to manage. But I think in those you need to go to a specialist centre because they're really not easy at all.
That's why absolutely, no, spot on, Tom, 100%. And that's why my last slide, I was thinking by finalizing the slide whether, because we work in cancer work now, so I value very much prevention or early detection, at least in the areas of the world whether this is pretty much a pandemic. Can we offer screening? Can we offer an ultrasound scan? Because if we detect it early, then we can afford several options rather than playing on the defense.
Well, I mean, screening, if you look at WHO criteria, you need to understand the natural history, you need to have a clear diagnosis and know the sensitivity and specificity of the test and so on. And we're not there.
But the data are hopefully promising towards that.
I think we may end there, but at the moment, I mean, someone needs to do some pretty big trials looking at overall test diagnostic performance, because you risk, because obviously what you're going to do about it, you see a scar pregnancy, a lot of women will say, well, the morbidity of this is such, I think I want to have a termination. But I mean, again, it goes back to the miscarriage stuff. You've got to have really, really, really good data. And that will take quite a big trial by somebody before we can, in my view at least, until you can recommend that. I think it's quite risky at the moment. And I do hear, and I hear people speaking at meetings saying we screen all our people, you know, for this. And I must admit I find that quite concerning, because I'm not to say that early diagnosis is obviously a good thing, but earlier diagnosis is also more difficult, in my view. I think it can be quite challenging. So
but maybe give you the time to afford giving the time to avoid the evolving of the condition.
Yeah. I mean, it's a debate.
So,
it's a debate.
Yeah.
I mean, but I think at the moment we're not there, in my view. But I accept your view. We're going to have to move on, Osama.
Thank you.
Sorry, you've added to your ChatGPT reputation there. Congratulations.
Thank you very much. Thanks.
I have a very important announcement to make, actually. I've been watching with great interest one of my fellows, George Lockett. I just wanted you to share this information with the audience, that he went on he's on a stag weekend. And the stag weekend was that at 3 o'clock, the team in the football league that scores the first goal is where they go. And they're going to Burton in the Midlands. I mean, this is an awful place to go. So I've had to try and give him some advice, because I once played rugby there, so there we are. We digress.